So hi, thanks for having me. So I'm going to talk a little bit more about implementing a program for managing opioid use disorder. Unfortunately, my presentation is very similar to Dr. Juni's. His is a little bit more in depth to the psychiatric and assessment. Can everybody hear me okay? Okay. Yeah, so and with that aspect, there is going to be some overlap, so I apologize for that. Some things I'll include, some I won't. So I've been working in maternal fetal medicine for 5 years. Prior to that, I was in labor and delivery. And when I was working in labor and delivery, I would see these moms, come in, and I thought to myself, what are you doing? Why are you using drugs? Just stop. Just stop. And then once, you get to know them and their story, I would probably be using drugs too. So I have had some women who have been molested by both their parents, their mom and their dad, have been prostituted out, had 3 STDs by the time they were 13. So I've had all of that along with women who have suffered from, physical and, of course, emotional trauma and suffer post-traumatic stress disorder. So let's see. So I have no financial disclosures for this. And here's some of the objectives that I really want to discuss and get you all to take home with you to your clinics. So provide a platform to cultivate critical thought and dialogue among those who care for pregnant women with opioid use disorder. Encourage medication-assisted treatment providers to care for pregnant women and make stakeholders aware of the adversity faced in their care. And then preventing other practitioners from recreating the wheel. So in developing a program for pregnant women with opioid use disorder. So here's just a little bit of what I'm going to go through today. A little bit of the background, which, again, Dr. Uni had touched on, so I might just recap that. The ancillary services that we have brought together to collaborate with for our program. Protocol development in our institution and how we implemented that. Education attainment, so how I was educated on this, as well as my staff. And then the prenatal, interpartum, so during labor, and postpartum management of these women. So opioid use disorder is a chronic, remitting, relapsing condition, has 11 diagnostic criteria, and if you remember, you need at least 2 diagnostic criteria to meet the diagnosis of opioid use disorder, excluding just tolerance and withdrawal. So this is a little bit about the data that Dr. Uni was discussing. So this just kind of puts it into visualization. So from 1999 to 2014, it was 1 per 1,000 hospitalizations for opioid use disorder. So down to a little bit of the terminology of opioids versus opiates. So opioids are natural and synthetic substances, and that's what, so they bind to the mu-opioid receptors, and that's what helps with pain, but it also gives that euphoric and the central nervous system depressant effects. And then opiates are a subclass of opioids derived from the opium poppy, and that's morphine and codeine. So I have to look at my notes on this because I want to make sure that I tell you the right thing. So this is kind of the pathophysiology, per se, of opioid use disorder. So this illustration is of the reward deficit disorder that characterizes any substance use disorder. So a lot of the times, these individuals with this disorder start out with a prescription, or they're, popping some pills just for fun at a party, and then based on, so that's where that controlled use is. So they're prescribed it, they're taking it as prescribed, or, they're taking some opiates occasionally. However, for individuals with a genetic predisposition and exposures and certain environment factors lead to the impulsive use, okay? So the next stage down, which is then mediated by the positive reinforcement of the high. So then they begin to use because they're liking that feeling of that high. And then with increased use, the neuroadaptation in the brain occurs, which results in poor functioning, like executive functioning. You're not making, not great decisions. And this results in, then goes to compulsive use. And so that's where it's mediated by the negative reinforcement of negative emotions and cravings. And so which eventually, once you're in the compulsive stage, and eventually you will need increased amounts of opioids to achieve the same effect. So again, you're chasing that high, but you never get that high anymore. It's more, you are maintaining yourself to prevent from getting dope sick. So I just wanted to make sure that I went down those steps. So here, type of opioids, so long-acting. Their onset of withdrawal is within 24 to 36 hours. However, it can last several weeks. This includes methadone, so a form of medication-assisted treatment, OxyContin, and fentanyl patches. Short-acting, their onset of withdrawal is 4 to 6 hours. So this is kind of like your heroin, your IV morphine, hydrocodone, codeine, oxycodone. These typically subside in 1 week. However, most individuals who are using these regularly don't get to that point where it just subsides. So, because withdrawal is like having a severe case of influenza. So here are some barriers that we have identified, and I'm sure you all have identified in your practices with getting women engaged in treatment. So the stigma of the addiction, these women feel shame, they feel guilt, like, why can't I stop, right? I'm in charge of my body, why can't I do this? Fear of losing custody is huge. They all think that if they're using drugs, their baby's gonna be snatched right out of the delivery room from them. Threat of incarceration and or mandated treatment. So in where I live, I'm from Indianapolis, and ours is, it's not a punishable offense. So I'm not sure what the laws are in your state. However, we do have mandatory reporting. We are a little more lenient when they present to us for treatment initially. The reason being is that most of these women, of course, they're going to have positive drug screens when they come in to our treatment. They are seeking help, and yes, they are probably going to be positive for opiates and some other drugs. But where it's a little gray. So you usually have to report if it's a mom with her first baby, you can't report until the baby is born. So that's a good thing, right? However, with a mom who is pregnant with her second or third or however many babies, most likely she does not have custody. So she is not essentially using around these kids. And so therefore, that's why we do not report them. However, if we do find out that they are in her custody, she is the sole provider, that's when we call DCS. However, that can be a great resource for them because sometimes, they'll pay for the services for her to have those home health visits. They'll get her in more intensive counseling. So that's where it can be very beneficial. But for that first-time mom, she can't have access to all those resources. We got to be pretty creative with that. I would say a majority of our patients are on Medicaid, which I'm sure that you guys have most of your patients on Medicaid as well. Feeling pressure from others, especially, their mom, their dad, their partners who are not using, pressures from that, like, you've got to get your life straight, you're pregnant. It's not just you, it's about this baby. Lack of child care, and then, of course, lack of transportation. We do have Medicaid transportation, however, they don't always show up. So that's been an issue that we have really encountered. And so in regards to our barriers, this is what we have really felt works well for our moms and how they feel accepted. So we have a welcoming, non-judgmental attitude. We keep promises. So that's big for our population, being somebody that they can trust. And when we say we're going to do something, we're going to do it, and we will help them. Just listening. Sometimes just listening. Like Dr. Uni had said, some people are, very quiet with their addiction and their history. Other people, it's like, ooh, I can finally unload on somebody. It's like word vomit of the mouth or diarrhea of the mouth, whatever. So be available, helpful, and positive. Keep patient informed. Address their complaints, and then always go the extra step if you can. So this is what we found to be very helpful with trying to get that, that whole comprehensive treatment plan and that whole group care, model. Mentors. So finding an OB provider or even a primary care provider that is knowledgeable in opioid use disorder, or an addiction psychiatrist, something like that, even if you can't pull them in, trying to use them as a resource for you. A pharmacy is helpful. Our hospital pharmacy, our outpatient pharmacy, is very familiar with our program, and they don't question our patients. We've had some outside pharmacies who have denied giving or filling their prescription because they're pregnant for even just buprenorphine. So a laboratory, of course, we utilize the hospital. We just recently moved to a point of care system, so a point of care urine drug screen, so that way we can address any positive drug screen right there in the office instead of having to wait until her next visit. So we can, really see what's going on, what led to this relapse, how can we get you the higher level of care. And then, of course, facilities that meet the American Society of Addiction Medicine placement criteria and accept pregnant women. We are lucky in that we have a place called Volunteers of America. Currently, I know they're in Ohio and Indiana, and they take pregnant women, which is super great. They are a federally funded program, and they can take women, of course, during their pregnancy and postpartum. And you can have 2 children under the age of 5 stay. So it used to be that they had to have an open DCS case so that DCS would pay for it. Now there's so many grants, due to the opioid epidemic. So from what I'm hearing, unfortunately, you guys don't have stuff like that. But hopefully with, this being an issue, there are some funds and hopefully something like that can be available. However, referring providers. So referring providers that refer to you because you feel comfortable taking care of this population, or referring providers where you can say, hey, I know that OBGYN is willing to prescribe buprenorphine or work with me to monitor her pregnancy while I prescribe her medication and somebody else deals with her behavioral health. So it kind of can be we used to have to, on to the next therapy. So it was, when I first started, we had one provider, which actually she's from Louisiana, and she just moved back here last year. So she was my director of our program, and she and I developed this maternal recovery program. So, and then bringing on therapy, we used to have to refer out of our clinic because we did not have a therapist. We currently utilize a group prenatal care model, so I don't know if anybody has heard of that. So currently we use centering pregnancy. So, but then also the March of Dimes has a group prenatal care as well. So and we find that to be helpful because group therapy is a form of course, therapy. So that does their OB care as well as their therapy requirement. And we thankfully have a psychiatrist now 1 day a week that we had to really fight for. Dual diagnosis providers are super important. However, we don't have that in our clinic. We have to refer out, and it's usually a psychiatrist, which of course our patients have Medicaid. Getting them into psychiatry is extremely hard. Even getting them a consult while they're inpatient is hard. Unless they have a plan, like a suicide plan, and they will not get to see them. Like it's impossible for us to. So, but dual diagnosis is really important because, like I've mentioned earlier, there's anxiety, depression, PTSD, borderline personality. There are a lot of diagnoses for these individuals. Being trauma informed, so having a case manager and or a social worker. This can be ones that are inpatient or outpatient that you collaborate with. A core nursing staff, so I have myself, my physician that I work with now, and one nurse who takes all the phone calls, who calls in the prescriptions, who kind of triages the patients and then talks with myself and my provider. So, and then of course, utilizing NPs and physician assistants. So here's the protocols that we have developed. So Screening and assessment policy, urine drug screen policies. How often are you going to screen them? What are you going to do for those positive screens? We still call them positive screens because they are. And then that's when we send them for confirmation. Induction, how are you going to start these moms on medication-assisted treatment? Doing it in the inpatient setting or outpatient setting? So we have done both. It kind of just depends on the patient. So, and then how do you expand your opportunity for education? So screenings and assessments, like the other two presenters have alluded to, is first you do a verbal assessment. You'd be surprised, like Dr. Uni had said, how many women will divulge that information to you. And then, of course, here's the instruments used, the 4 Ps, the substance use risk profile during pregnancy, the TACE, and the cut down or the tweak assessment tool. And then toxicology screens, again, those are not always standard for everybody. And then, of course, looking at your prescription drug monitoring programs, which can be very helpful. Even if you're prescribing any type of controlled substance, it's always great to look at that. And sometimes you can look at different states. Our program, you're able to look at some different states, but not all of them. So you want to keep in mind your state laws in regards to reporting substance use. Are you to report during pregnancy? Do you have to wait until after delivery? What are your laws? So like I had discussed earlier, your treatment plan should be individualized, and you should educate these women on the legal, social, and medical consequences of any medication that you would prescribe, or if they chose to do detoxification. What would happen if they relapsed, all of those sorts of things. So it's a whole, informed consent. And then discuss the medication-assisted treatment, and then I'm going to talk a little bit about medically supervised withdrawal. So here are the current recommendations for opioid use disorder in pregnancy. So classically, detoxification was found not to be accepted. The reason being is this was based on 2 studies in the 1970s, okay? There were 2 bad outcomes for women who had withdrawn. One was a really early pregnancy, and the other one, I believe she had co-occurring like polysubstance use. But that was where it was, hey, it's not safe, baby could die. And that's still the misconception now, is that if you detox, you're detoxing, the baby's detoxing, you could die, and the baby could die. Well, sorry, baby could die, not I mean, no one's really ever, I don't know if there has been people who have died from detoxification. It's probably more because you use again, so then you overdose. So, however, the preferred method is pharmacologic along with the behavioral. So it's that comprehensive care. So just a little bit more. So it can be cognitive behavioral treatment. So it can be one-on-one, it can be group, but then also looping in that prenatal care. So here's just the mechanism of action of the drugs that are used for opioid use disorder. So methadone, long-acting, synthetic, man-made, full opioid agonist that is slowly metabolized, so it has a longer half-life. So it stays in your system much longer. Buprenorphine, short-acting, synthetic, partial opioid agonist with, again, like he had mentioned, a high affinity. So it can overtake that opioid receptor. Naloxone, so that's Narcan. So it's an agonist. It blocks the opioid receptors, preventing opioid effects. So it's used for overdose. Okay, so I guess just a little bit about this again. So it's been utilized since the 1960s, methadone has, for individuals with heroin-associated addiction. Then in 1970s, it was starting to be used for pregnant women with opioid use disorder, prior to it being called opioid use disorder. So the reason that it is the gold standard for pregnant women is just because it's been around longer. They have more data, more research. So it does have to be dispensed in an opioid treatment program. They have to follow federal and state regulations, and it's unable to be prescribed. Methadone, while in an OTP, has lower abuse potential, lower overdose potential, less diversion, because in our clinics up in Indianapolis, they give it in the liquid form. So you can't cheek it and then, go out there and spit it out. So if you could swallow liquid and regurgitate, you're pretty talented. So that's where it's the less diversion risk. So it does prevent withdrawal, but you can't initiate it before withdrawal symptoms first start. So sometimes that can be beneficial, but it kind of, again, it's individualized. I think that was all. I thought I had extra notes on this. So let's see. So highly effective. Whoops, sorry. There I am. Okay. All right. So it is considered safe in pregnancy. There's been no clear associations with congenital anomalies. Like I said, the half-life is pretty long. The reason that there's such a wide range from the 25 to 52 hours is, again, all the physiological changes during pregnancy. Unfortunately, if you are a woman and who have been pregnant, our weight increases, right? So our blood volume increases, our liver metabolizes medication faster. So that's where the big gap in the half-life can be from. Several drug interactions, especially a lot of our patients are taking benzodiazepines. Not prescribed, but they're taking them. And when that is identified, we then taper them. However, I would be opposed to starting a mom on methadone while she's still on benzodiazepines, just because of, the whole non-sealing effect, and the benzodiazepines with the methadone increase risk of overdose. Side effects include sedation, respiratory depression, and prolonged QT interval. So that's where so an EKG is recommended at time of initiation for these women. And then buprenorphine. So that's either buprenorphine or the combined buprenorphine naloxone. So it's considered safe in pregnancy. There have been some studies that when rats were injected with buprenorphine, that they had some bone abnormalities. However, that's not been shown in the human population. The most common side effects are headache, especially with the combined buprenorphine and naloxone. Anxiety, constipation is obviously an issue with opioids, and pregnancy. So that is really uncomfortable. So you want to make sure that your patients are, educated on over-the-counter stool softeners, Miralax, those types of things. Perspiration, which of course hormones make you sweat anyways. Fluid retention in the lower extremities, which of course, if you've ever been pregnant, those ankles swell. So urinary hesitancy and sleep disturbance, which can be difficult for this population. Sleep is anyways. So a lot of the times, they're trying to get their brain to calm. They can't. They're used to taking something to fall asleep. You have vivid dreams when you're pregnant. Sometimes you have, nightmares from PTSD. So that is a huge issue. So what can help that is not taking the buprenorphine so late into the evening. Can hopefully help with some of that insomnia. So again, here is just a diagram of the methadone, the full agonist, where there is not that ceiling effect, where you can go up and up and up and up and up. So I have seen in our practice or in labor and delivery where after a mom takes methadone, she's unfortunately she's high. So it's a very fine line. Yes, there are some women or some individuals who are on methadone a very regulated dose, and it does help with their withdrawal symptoms. However, unfortunately, some of our clinics don't see it that way. It's more of a money thing, which is unfortunate. But you will see, if you do work in labor and delivery, you'll see these effects on mom, but then also on the fetal monitor, you'll see these effects on baby. And so, depending on when that baby is born for mom's dose, you'll have that respiratory depression. So these babies aren't going to want to breathe on their own. So a lot of times they need that extra oxygen supplementation. And then versus, of course, the buprenorphine. So that has that ceiling effect. And up to about 24 milligrams a day, there's no added benefit. However, there are some that are For chronic pain, Suboxone that is prescribed up to 32 milligrams, and that's split dosing all day to help with some chronic pain. And then naloxone, Narcan, of course there's no opioid effect. So here are the advantages of both buprenorphine and methadone. So as Dr. Uni had alluded to, neonates with neonatal abstinence syndrome required 89% less morphine, had a 43% shorter hospital stay, and a 58% shorter duration of treatment. So treatment as in the NICU on morphine. That's what we utilize. I do know that there are some hospitals around our area that have switched to like as needed methadone to taper these babies off of buprenorphine. I'm sorry. Oh, sorry, I thought you had a question. A lower risk of overdose due to that ceiling effect, fewer drug interactions. Mainly the biggest ones with buprenorphine with drug interactions are antivirals for HIV. We have a couple of those women. However, we monitor their liver function and work closely with their infectious disease to monitor them, and we've never had to take a mom off of her buprenorphine because of her HIV medications. And of course, it's an outpatient treatment, so that can be great for the moms who have been, stable in their recovery for a while. They find out they're pregnant, they have full-time jobs, they have families. They can do this outpatient. They don't have to wake up at 5 a.m., drive to the methadone clinic, wait in the line, and all of that. So, however, methadone can be an advantage for individuals who need more of a structure. So that's always a benefit. Disadvantages, risk of hepatic dysfunction. A lot of our women, I would say probably 85-90%, have hepatitis C. And so for that reason, we will monitor their liver functions, usually initially. So usually once we initiate them onto buprenorphine, and then again at their 28-week labs. There is a lack of long-term data on infant and child effects, just because it's not been utilized. It's been utilized since the early 2000s for opioid use disorder and pregnancy. So there's lack of the long-term data, but then there's lack of follow-up. Like, are these babies still with their parents? Are they with grandparents? Our population moves a lot, so we can't follow up on them. Again, the importance of patient dropout rate due to dissatisfaction, having to follow the rules. They're not always keen on that. And then a risk of precipitated withdrawal with induction. So yes, we have our moms wait until, or our pregnant patients wait until they're in at least minimal withdrawal before we initiate them onto buprenorphine. So, however, there is a risk of diversion. So, and it could be for multiple risks or multiple factors. Most of these women do not have jobs, or their partners have history of opioid use disorder, and they don't have insurance. It's hard for them to get in. So they're saying they have withdrawal symptoms so that they get more buprenorphine. There is no medical test to say, hey, yes, you're experiencing withdrawal symptoms. Yes, you tell me you're withdrawing. I'm going to give you more medication most of the time because I don't want relapse. So that is difficult. And yes, we can test for like the metabolites of buprenorphine, but depending on when they took it, how fast they metabolize it, we don't know if they're taking all their dose. So disadvantages of methadone, it does require that daily visit. In our area, we have 2 or 3 in like downtown Indianapolis, which we're in the central part of Indiana, and only 2 outside of Indianapolis. So a lot of our patients in our clinic do not come from Indianapolis, Marion County area. They come from outside counties. So if they need that higher level of care and they need those daily visits, it's going to be hard for them, especially if you remember back to lack of transportation. So that's huge. And then, of course, the risk of overdose. So when should you initiate medication-assisted treatment? So, as early as possible. If you're going to choose inpatient versus outpatient, you want to titrate to symptom relief. And then what's the difference between the buprenorphine versus buprenorphine naloxone? Which I think I might have some more information on that. Yeah. So the medication of choice for each patient needs to be individualized. She should know before that she and her providers will decide which medication is best for her. I want to select it first before I go down. So in regards to methadone, a woman should know it can take days or weeks to achieve a therapeutic dose. So they go to an outpatient clinic, of course. They give them their first dose, which usually it's 20 to 30 milligrams. Then they titrate every couple of days. So that's where it can take a while to have to reach a therapeutic dose. So and then if a woman wants to switch, say she gets pregnant, she's already on buprenorphine, or she's on methadone, she's like, hey, I want to get on buprenorphine, that switch is much harder to get back from methadone to buprenorphine versus buprenorphine to methadone. You have to get down to 30 to 40 milligrams of methadone before you can transition to buprenorphine. Or, again, until she experiences withdrawal symptoms, which with methadone, that half-life being 25 to 52 hours could be quite some time. So for pregnant women, it is appropriate to initiate these in an inpatient setting. So does anyone have the ability, do you guys know if that's being done for buprenorphine in like an inpatient labor and delivery or even like a medical surgical unit? No. So I've also done it in the outpatient setting as well. I do telehealth for an addiction treatment center. And so we do have some pregnant women that come through and, we do that education with them that, you're waiting until you're experiencing at least mild withdrawal symptoms before you're taking your first dose. You'll take a half dose, so 4 milligrams, and then you see how you feel 2 to 3 hours later. If you're still experiencing withdrawal symptoms, you take additional 4 milligrams. So you don't want to take more than 16 milligrams in that first day. So, which is typically the common dose. However, with heroin being stronger, with it being laced with in our area, carfentanil, so like elephant tranquilizers, a lot of individuals require higher doses than 16 milligrams. So, okay. So again, comorbid behavioral health disorders. So like I said, a majority who enter our treatment have histories of abuse, trauma, domestic violence. These can definitely complicate them, and so it can be a very challenging population to work with. So obtaining, again, that psychosocial history is important, and asking about trauma, depression, anxiety, and other mental health diagnosis, which can be difficult because some of these women were diagnosed during their drug use. So it can be drug-induced anxiety, depression, psychosis. A majority of the time it is not. However, typically you need to be substance-free for usually 6 months, and I mean substance-free as in like illicit drugs. So buprenorphine and methadone obviously maintains you at a therapeutic level. So then you can truly assess for a psychiatric illness. And then, like I said, examples of drug interactions, respiratory depression with benzos are when combined with buprenorphine and methadone, and then prolonged QT interval, so when somebody is taking methadone with SSRIs, so commonly used medications for depression, as well as tricyclic antidepressants. So those and antidepressants, anticonvulsants, which some are utilized for anxiety, and anxiolytics, benzos, may increase the severity of needle abstinence syndrome. Like he had mentioned earlier, tobacco is huge. I would say, I think my nurse calculated just last year, we had 94% of our moms smoke tobacco. Yeah. So I even have some moms who chew. So that's interesting. So here's a little bit of the prenatal care for these women who are on medication-assisted treatment. So you want to titrate since you would most likely be the outside provider, unless you are in an opioid treatment program, you're going to be titrating their buprenorphine. So, and you want to titrate that up to symptom control. Sometimes, due to the physiological changes, it is not uncommon for a mom to say, hey, I feel like it's wearing off by the end of the day. So then you suggest, hey, how about you try splitting your dose? So say a mom's on, 8 milligrams. She takes 4 in the morning, 4 in the afternoon. Remember, not too close to bed, because it can keep her awake, along with peeing all night and nightmares and all those things, like you're going to birth a horse or something. So, so sometimes you want to split your dose before increasing your dose, okay? Because, you're limited to that 24 milligrams. So it's not uncommon to have to increase it several times during pregnancy, the third trimester being the most, common time. So you want to, if you do not have all of these, you want to try and reach out to an obstetrician who is comfortable with this, or at least knowing that she is on buprenorphine or medication-assisted treatment. An addiction and behavioral health care. And a big part where we live is with the rural facilities, they are not comfortable managing neonatal abstinence syndrome or even assessing for it. So these babies get whisked off to like a level 1 or level 2, NICU, so that they can be assessed. You take my baby from me for something that I did, those moms are already a high risk of relapse. That's going to be huge. They already feel guilt and shame. So making sure that they can deliver at a hospital that's comfortable so that mom and baby are not separated. And then how long are these babies going to be observed? So with buprenorphine or methadone, if a mom does not take it every day, she doesn't get withdrawal symptoms necessarily the next day, depending on that half-life. So for a baby who's been exposed to buprenorphine, symptoms will typically begin to exhibit neonatal abstinence syndrome symptoms, typically starting around day 2 or day 3. It peaks between day 3 and day 5. So I don't know about your facilities, but for a vaginal delivery, our moms go home in 48 hours, or even less if it's uncomplicated. For a C-section, they are discharged at 72 hours, so that's 2 to 3 days. So when these moms are discharged, with these babies, they have they're going to be discharged, then these babies are going to begin to withdraw. And that can inhibit feeding, inhibit sleeping, which can lead to, abuse, because sometimes poor coping skills, you'll lash out at baby, shaking baby syndrome, you wind up in like unsafe sleep. So there's a ton of things that can correlate with that. So making sure that these babies who are exposed to medications while in utero are observed for an adequate period of time. In our facility, we monitor them for a minimum of 5 days. Does that mean that they go home at the 5 days? Yeah, they can go home at the 5 days depending on their symptoms or severity of neonatal abstinence syndrome. Neonatal abstinence syndrome is expected with all babies. We prepare our moms to have to stay in the NICU. I tell them I wish I could put my hand on your belly and say, hey, your baby's gonna withdraw this bad, you're gonna be in the hospital this bad. If I did, I would not be doing what I'm doing, and I would, just be like own my private island. But so we prepare them to stay. The mean amount of time that our moms and our babies stay in the NICU, if they have to go to the NICU, is 19 days. So that's quite a bit of time. However, we are trying to move towards Eat, Sleep, Console. Have you guys ever heard of that? So, because currently we're using the traditional Finnegan score, okay? So it is like 20 to 21, assessment points, and based on their score, that determines, hey, does this baby need to go to the NICU, or does this baby need to be started on morphine? So when a baby has 2 scores over 9 or 1 over 12, that automatically gets them to the NICU. And then, of course, if their scores start trending higher, then that baby gets started on morphine. And what they do is they titrate the morphine up based on baby's weight until they can capture the withdrawal symptoms, meaning that this baby is comfortable, similar to when you initiated buprenorphine on mom, and then slowly, every day or so, they taper it down. So it kind of just depends on the baby. However, I think I get to this in my NAS. And then, of course, involving social work or, reporting to DCS if, necessary. So here are just some extras for our moms. Of course, I said, a higher incidence of hepatitis C. So you want to make sure that you are monitoring their liver function, and then of course doing a TB skin test for that high-risk population, so for recently homeless or recently incarcerated. Importance of smoking cessation, of course, health of their baby, the pregnancy, you're more likely to have low birth weight babies, a higher risk of preterm delivery for those individuals smoking. Contraceptive is huge. So, what we want to talk about, hey, how do you want to prevent pregnancy in the future? The importance of making sure that we can focus on mom, your sobriety before you get pregnant again. So, because this is the first time she could be navigating life sober in a while, and to have 2 back-to-back pregnancies is setting her up for, a relapse. And then talking about the importance of breastfeeding when contraindicated. So buprenorphine, methadone is not a contraindication to breastfeed. They get a little bit of that medication through their breast milk, but then that skin-to-skin and sucking is very therapeutic to a baby who's experiencing neonatal abstinence syndrome. Hepatitis C is not a contraindication to breastfeed unless they have cracked or bleeding nipples. So we do a lot of education about, preventing skin breakdown and looking for those signs and symptoms. Sometimes prophylactically using a nipple shield can be beneficial for these moms. And it helps to ease their mind too. So intrapartum care for women on medication-assisted treatment. So during labor, you want to continue their dose of medication-assisted treatment. Pain control. So you, of course, want to utilize all the non-pharmacologics before, going towards anything else. That's walking, the birthing ball, showers, tubs, those types of things. And then neuraxal anesthesia, so epidurals and spinals. So you want to avoid, we use Nubane a lot for our moms in labor for pain management, ones who want to do like natural childbirth, or even just to take the edge off before they're, bed, confined to the bed with an epidural. And so, however, you want to avoid that and other mixed opioid agonist, antagonist with these women because it can precipitate withdrawal. So if you could imagine, you're in severe pain from labor and you're given Nubane, withdrawal, and labor, that it would be miserable. When I was still working as a labor and delivery nurse, I had a mom. I was taking my lunch break. I had another nurse covering for me. She called me and said, hey, so-and-so is asking something for pain. She has this ordered. Can I give it? And I said, yeah, sure. You can go ahead and give it. Well, she did, and the whole unit could tell that she was uncomfortable. She had been taking methadone off the street. No one knew. Her provider did not know. She was going to all her OB visits. She did not screen positive, but she was taking it off the street, and so that put her in withdrawal. So then, she's in labor, she's in withdrawal, we're giving her this methadone to prevent her withdrawal from getting worse. She was just miserable. So here's what you want to do in the early postpartum care for these moms. So early as in, right when they delivered up to, 6 weeks, 8 weeks postpartum. Continue their medication-assisted treatment. And they may require higher narcotic doses post-cesarean because their opioid receptors have been flooded for so long, and their perception of pain is higher than, the typical healthy individual. Encourage breastfeeding unless contraindicated, which we kind of touched about that. Based on reports of post-cesarean overprescribing, we discharge our moms on Percocet 20 tablets. So that's enough for, anywhere from 4 to 5 days. If they are requiring something that's strong after that time, there's something wrong. So again, we then talk about the non-pharmacologic ways to manage pain after a C-section, like using your arms and legs as much as possible, rolling to your side, pushing up with your arms to get out of bed. That abdominal binder is great. I think I wore that for like 2 months after I had my son. Ice, heat, those types of things. Ibuprofen, of course, is huge. And then in the late postpartum, so probably after 6-8 weeks, these are things that you kind of want to be aware of. So buprenorphine is not typically reduced. That's just another stressor for that mom. sleep deprivation, postpartum depression. A higher risk of postpartum depression in this population is very common. So to decrease her buprenorphine dose at that time, may put her over the edge. But again, it's individualized. I've had some women who have been tapering prior to pregnancy, find out they're pregnant. They're like, hey, I'm going to stay on it because it's a recommendation, but I want to get off of it as soon as possible. So, but again, it's all individualized. However, methadone may need to be reduced due to oversedation because, again, it does not have that ceiling effect. So you want to assess early and frequent for relapse and postpartum depression. So hopefully you would kind of be, screening them for depression at every visit. We do the Edinburgh depression scale at every visit with our moms. So here's a little bit more about neonatal abstinence syndrome and the two methods that are being utilized in most hospitals. So like currently we are using a modified Finnegan scale because we're trying to go to eat, sleep, console. We cannot offer that yet because we can't always guarantee a mom that she can room in because we just don't have the space for it. However, we will find her a room for her to stay in the hospital. It's not always on our unit, but we will find her a room so that, because we talk about the importance of, couplet care and that mom is the best medicine for her baby during neonatal abstinence syndrome. We are trying to move towards eat, sleep, console. What that is this baby eating well, right? So they seem satisfied after eating. Sleeping, are they sleeping an hour or so after eating? Are they easily consolable? So, meaning can this baby be calmed down within 10 minutes or so? I know that my son, he probably would have scored on, I'm not on medication-assisted treatment, but he would have scored on the Finnegan on a bad day. So, he went from 0 to 100 in no time, like he was hangry and like he could not be satisfied at some point. So, any baby can really fall on this. It's high-pitched cry, inconsolable, excessive sucking, those can all be factors to determine the severity of neonatal abstinence syndrome. So that's where we're trying to treat babies like babies because all babies can have difficulty feeding. All babies, whether it be with a bottle or with breast milk, all babies can struggle with things associated with neonatal abstinence syndrome. SSRIs can increase the severity of neonatal abstinence syndrome, as well as the other medications, like we prescribe trazodone a lot for our moms for sleep. Those types of things can increase the severity of neonatal abstinence syndrome. And of course, when did they initiate onto MAT? Were they using up until 28 weeks? This baby is going to have illicit drugs in their system. Meconium starts collecting around 20 weeks. So that's, if a mom is still using up until that point, the baby is going to have to withdraw off of that as well, along with the buprenorphine and any other medications that she may have been using. Screening, so we, if obviously we know that there's a history of drug use, we screen the baby's meconium, urine, and umbilical cord. Umbilical cord goes back to about 28 weeks, so any third trimester drug use. Management, so we discuss the non-pharmacologic ways to manage it, and then of course the pharmacologic ways to manage it. So this is important with your moms to discuss this prior to delivery so that they can expect this and how they can manage it and how they can comfort their baby during this time. So, I guess I thought I went into more discuss that. So non-pharmacologic methods for these babies are skin to skin. So that can be done with mom, dad, grandma. That is really important. It's very soothing to any baby. Breastfeeding, like I had mentioned earlier, baby gets a little bit of the medication through the breast milk, and sucking is comforting to a baby. Keeping the lights low, keeping it quiet, limiting visitors. I know everybody is excited about this new baby, but do not pass that baby around. The baby's going to get irritable, and it can increase scores. Also, doing the Finnegan assessment or you're scoring while baby's on mom's chest, unless there are some things you have to take away for to like look for reflexes. But doing that score while baby's on his chest, like I said, my son, if he was not being held, 0 to 60, like he could have scored and he probably would have had to go to the NICU and start on morphine for just being away from me. He's still like that at the age of 3. So he is true, and I love it, but I hate it at the same time. So, and then the pharmacologic, again, typically those babies are sent to the NICU. They are put on EKGs, like O2 saturation monitors, because of course they're going to get started on either morphine, methadone, phenobarbital, depending on how severe and what they're tapering off of. So it is important to be aware of polysubstance use. So these are women, a majority of them are taking more than one substance. So alcohol, methamphetamine is huge where we're from. So I don't know, is that big here too? Yeah. So benzodiazepines, again, anxiety. These individuals do not like to feel feelings. They don't like to feel things. And so the benzodiazepines help with that, and it's usually the short-acting, like Xanax. So that's the only thing that works for them, right? Marijuana, cocaine, and of course, like I said, the 94% of our patients who use tobacco. So this is just going to go into, I know this slide is a little overwhelming, but here's the management for these polysubstance abuse disorders. So some of these can be, medication can be utilized for them. Others, like cognitive behavioral therapy, is the recommendation. So for alcohol, management with benzodiazepines, that is for a short term, and usually that's in the inpatient setting. So you're bringing these moms in, you're doing, it's a withdrawal of alcohol protocol that we utilize, and you do administer benzodiazepines on an as-needed basis so that she can, wean off of the alcohol. Moving forward, though, for a mom who has opioid use disorder and alcohol use disorder, we have utilized Vivitrol in these moms because it works for both, and we want to helpfully prevent any relapse with, say, we are prescribing buprenorphine, but she has a high risk of alcohol use disorder. Yes, it's most likely not utilized in pregnancy. Vivitrol is, however, there are studies that it has been utilized in pregnant women. And then, of course, the effects of fetal alcohol syndrome and how to prevent that. And it's one of the most common causes of developmental delays in children. So for amphetamines, methamphetamines, there's no medication for that, unfortunately. It's intensive outpatient behavioral health services. A lot of the times that is, we call it IOP. I don't know what you guys call it, but it's like 2 to 3 times a week, sometimes even more than that. So benzodiazepines, typically we assess the individual. How much are you taking? What are you taking? And then what has happened if you have gone cold turkey off of it. Some women have, especially if they have a history of a seizure disorder, we will gradually taper them. For women who don't have seizures or don't have a history of a seizure disorder, then we will do more of a quicker taper, I guess. But again, it's individualized, and we switch them from a long-acting, I'm almost done. A long-acting to, I'm almost done. A long-acting to a short-acting, such as diazepam. Tobacco, we educate them on, it can decrease the severity of neonatal abstinence syndrome, decrease childhood illnesses such as asthma, and decrease the incidence of SIDS, so sudden infant death syndrome. Now it's like SUIDS, sudden unexpected infant death syndrome. So we do offer nicotine replacement therapy. I rarely do Wellbutrin for moms because I found that it makes anxiety worse, so that's like the least thing you want to do. So, and then marijuana, it's behavioral changes, and then cocaine, again, it's cognitive behavioral therapy. So some of the conclusions, again, you want to screen all pregnant women for substance use disorders, any co-occurring mental health issues, infectious, and STDs, as that can cause preterm labor for any untreated infection during pregnancy, and of course be passed to the baby. And then physical and sexual trauma or violence. You want to refer these women to OB who are experienced with or have any knowledge of opioid use disorder in pregnancy. And then, of course, medication-assisted treatment is the recommended treatment for opioid use disorder in pregnancy, along with behavioral therapy. So what can you do? You can explore the resources available on the SAMHSA website. Like Dr. Uni had showed that they have a whole tip for pregnant women with opioid use disorder. Join the American Society of Addiction Medicine. Attend conferences such as this that are available local or national. Learn about your state's regulations for reporting during pregnancy and after. Complete the buprenorphine waiver training. It's offered free through SAMHSA right now. So even if you're not a prescriber, it can be very beneficial because it just gives you a little bit more into it. And then seek out local resources and create your own referral network. So here's my contact information. I don't think I have much time for questions, but I will be here the rest of the day. Does anybody have any questions? Okay, great.